A very warm welcome to this Cataract and IOLs Explained session. This is going to be very interesting. I'd like to request Dr. Lipi Chakravarti, who is the moderator, to please invite the first speaker.
Yeah, sure. It's Sunday morning, and I think half of the janta is at Mussoorie or adjacent places. So whomsoever we have in this hall as speakers, I'll call them by this order. So I can see Dr. Rajendra Prasad, sir. He is having the first presentation, Intumescent White Cataract, Imminent to Argentinian Flag Sign Management Pulse. We have been watching RP sir in various conferences and meets presenting this Argentinian flag sign, how to overcome this. So over to you, sir. Rajendra Prasad sir has certain techniques, videos he has shown in many meets. How to do capsular excess and intumescent white cataracts.
Thank you very much, and good morning to all of you. The topic which I'm going to present is intumescent white cataract, imminent to Argentinian flag sign, and how to prevent it. So I'll be telling some management pearls for this. You know that these intumescent white cataract, they present in a different clinical presentation. You may have an intumescent soft immature cataract, you may have intumescent mature white cataract, you may have a intumescent hypermature white cataract, and then finally the Morgagnin cataract. So whatever is the type of these intumescent white cataracts, they have a common presentation, the common feature. So that is, they all have a very thin and fragile capsular bag, and secondly, they have a very high interlenticular pressure. And third important point is, they have a tense and stretched out anterior capsule. This can be detected, and we can find out with the help of the OCT images. And you can see in the OCT image, you can see a hypermature hydrated swollen cataract. You may see very shallow anterior chamber, tense and stretched out anterior capsule. You may see some fluid vacuoles, multiple fluid vacuoles in the anterior cortex. And the important point is shallow AC, because so you have a very less space to work in the anterior chamber. And if you tend to puncture this capsule with the help of the hypodermic needle or the capsular access forceps, क्या हुआ? नहीं है? छूट रहा है. मेरे पास भी है, लगा दूं?
Sir, if there's a problem, you can load your presentation on theirs and Anaga can present until then.
आगे? Hopefully.
इनका presentation आप अपने कंप्यूटर पे ले लीजिए.
नहीं, आगे उनका वो वायर भी काम कर रहा है.
यहाँ नहीं आ रहा सर, सामने टीवी पर.
उधर लोड कर दो। Ready now?
एप्पल का लैपटॉप है क्या? हाँ,
Okay. So I think, sorry for the delay. And so as I was mentioning about the OCT images, you can identify and classify these intermittent white cataract with the help of the OCT images. And the important thing is, like when you puncture these capsule, what happens with the needle or with the capsular access passages, there would be a volcanic eruption of the fluid which comes out. Now this eruption of the fluid is because of the pressure inside the interlenticular space, and this eruption is fluid as well as the gas. So many times the gas also comes out from the capsular bag because the presence of the gas which is there in the capsular bag. And with this, many times when you puncture the capsule with the needle, this is how we do normally. We use the hypodermic sharp needle to puncture, and this puncture starts extending to the periphery, and it forms a radial tear on the anterior capsule. And this also happens. So one of the technique, we know that the intralenticular space fluid aspiration with the needle, that is prescribed technique to prevent the Argentinian flag sign. But even with this needle also, like when you try to aspirate, before you could aspirate anything from the interlenticular space, the puncture starts extending to the periphery. So this happens with the needle also. And this is called as the Argentinian flag sign. It was described by Perone somewhere in 2000. And this used to be one of the most common complication which happens with the intermittent white cataract. The reason, what could be the reason why it is happening? Because so we did some study on this, and we found out that when you are puncturing the capsule with the help of a needle, you are making a cut on the anterior capsule, a simple cut. See, you see the linear cut on the anterior capsule. This is what happens when you use the needle, hypodermic needle. And if you use a capsular rhexis forceps, so before initiating the rhexis, what we do, we normally tear the capsule, either with the needle or with the rhexis forceps. Now this tear actually is the reason which tends to extend to the periphery. And this linear cut which we make on the anterior capsule, so this is more prone to extend to the periphery. So this does not have much of the resistance if there is a pressure inside the capsular bag. A tear would extend very easily to the periphery. And you know that almost 7 to 24% of the cases, the radial tear, anterior radial tear, goes into the posterior capsule. And if goes into the posterior capsule, you know the complications like vitreous loss, lens material drop, and you may completely lose the capsular support also for the interlenticular IOL implantation. So what we can do, what is the solution? The solution is you need to decompress the bag preoperatively, or you can do decompression of the bag intraoperatively. So preoperatively, what you can do is you can give the patient preoperative mannitol. So this is one of the technique. Although this preoperative mannitol will not decrease much interlenticular pressure, it may decrease the intraocular pressure, but not the interlenticular pressure. That is one thing. We can do ocular massage. So this is one of the very simple technique we have been doing when we used to the intracapsular cataract extraction. Do a good ocular massage. We can put a partial limbal incision. So in the beginning, just put a partial limbal incision, or you can start the capsular rhexis from the side port. Don't give the main incision. And always use highly cohesive viscoelastic so that you pressurize the anterior chamber and pressurize the anterior capsule. And many times, one of the very simple technique described in a very high interlenticular pressure is the posterior decompression also has been described. So what I personally prescribe, one of the very simple technique is saving needle microcapsulotomy. So what is this technique is? This technique actually is the creation of puncturing the anterior capsule with the help of a needle, which is like a sieving needle. It's not like a hypodermic needle. Hypodermic needle has a sharp cut. So when you puncture the anterior capsule with this needle, you will make a hole. So as you can see here, that it makes a hole. But if you puncture with the hypodermic needle, you get a linear cut on the anterior capsule. So instead of making a linear cut on the anterior capsule, if you make a hole, a small hole puncture on the anterior capsule, now this hole has a much higher resistance against any kind of intralenticular pressure, and this will not extend to the periphery easily, like the linear cut on the anterior capsule. So this is the biggest thing and biggest difference between making the linear cut and the hole. So how you can do is very simple, like what you have to do is always stain the capsule with the trypan blue and pressurize the anterior chamber, make a hole like I'm showing you the animation on the left side. This is the needle we use, and when you puncture the anterior capsule, you make a hole and you can evacuate the fluid from the intralenticular space. Now this fluid will, the evacuation of the fluid will decompress the back. You can use a simple saving needle as I am trying to do in the second video. This is a simple saving needle. You just have to bend the tip of the needle and then puncture. So when you puncture with this needle, you make a hole on the anterior capsule. Now this hole, you can use a straight needle also to puncture the anterior capsule, like you can see in the video. And you see the evacuation of the fluid which happens when you puncture the anterior capsule. Now this evacuation actually leads to decompression of the back, and your anterior capsule becomes very relaxed and flat. So unlike a very stretched out anterior capsule, now if you have a flat and decompressed back and relaxed capsule, then you can very easily complete the capsular axis. Now you can do the milking technique also along with this, because with what has been described, milking technique is you take the visco cannula to the periphery and bring the fluid to the center and evacuate from this puncture which has happened on the anterior capsule in the center. And then with the help of the capsular axis forceps, you just tear the capsule and start your capsular axis very easily without any threat to extension of the capsular tear to the periphery. Because your capsule is now absolutely relaxed, and you can very simply do the capsular axis. And the other, I think I have 1.5 minutes more now. So the other factors which could lead to the Argentinian flag sign during the capsular axis also, because these happens because of the disturbance or the imbalance in the interaction of the vector forces. So vector forces which are used to create the capsular axis, and the reasons for that is either there is a certain evacuation of the viscoelastic from the anterior chamber, your vector forces are not, you are not taking your capsular axis the forces correctly, because you are not putting the centripetal force, and there is a disturbance between centripetal and centrifugal force, so your capsule may extend to the periphery. This is called as a partial Argentinian flag sign. You don't get the radial tear, but you may get a tear which is extending to the periphery. And for this, there are certain technique which has been discovered. I'm not going to show you the video now, because you all know one-stage spiral CCC and two-stage spiral CCC. Like you can start a small axis in the center and then slowly take it to the periphery and increase the size of the axis. So I'll not just, because of the time, I'll not show. I'll just show you half minute. This is posterior decompression. If you think that nothing is working and the pressure is not coming down at all, the intralenticular pressure or intraocular pressure, then you can do the posterior decompression. Just take a vitrectomy probe into the posterior chamber. So before making that, this anterior segment, because I'm doing this anterior segment, surgeon can also do. You just make a port with the help of their 26 gauge or 23 gauge needle, and once you make this port at the pars plana region, and then you take your vitrectomy probe and take inside, and you can evacuate some of the vitreous from the anterior vitreous, actually, because you're trying to do the anterior vitrectomy, a little anterior vitrectomy, and this will decompress your bag as well as the intralenticular pressure, and then you can very simply start your capsular axis and complete the axis without any threat to the posterior extension. So thank you very much.
Thank you, sir. Just one question, sir. Dr. Harbanslal was showing a procedure in which you make a paracentesis, and with your irrigation cannula, aspiration cannula, he was swiping over the anterior capsule with the hypothesis that with the scientific logic that there are air vacuoles also in between in these liquefied cortex in this intumescent cataract. And when you're making a swiping action, these air gets filled with the liquid, and then he has done over 130 cases, and he's saying he never gets a Argentinian flag. He doesn't need to use any of the procedures. He just sweeps for 30 seconds.
Because with this technique which I was showing, saving needle microcap slot meal, because as I said, if you are able to detect the multiple pockets of the fluid with the help of the OCT, or you see the fluid air vacuoles also in the interlenticular space, then you can puncture with this. It's not necessary to make a single puncture. You can make a multiple puncture. You make a puncture where the vacuoles are there. You just release, so you don't have to sweep or do anything. You just puncture at that particular point. And actually what happens is basically it's very limited fluid is there inside. It's not like you have 3-4 ml. You have hardly 0.5 ml of the fluid in the interlenticular space. And if you are able to evacuate even 2 drops, your capsule will relax. So you don't have to do sweeping, this and that. You just make one puncture, 1 drop of the fluid comes out, your capsule is relaxed. That's it.
Thank you, sir. Thank you very much. We'd like to call the next speaker. Bhargav is not here, no? So we'd like to call the next speaker, Dr. Anaga Harur, who will be speaking on Ray 1 trifocal. Dr. Anaga Harur is the ARC member from West. She is also the president of Maharashtra Ophthalmic Society, a very, very dynamic ophthalmologist. Dr. Anaga Harur.
President-elect. Okay.
Yeah.
Okay. Thank you so much. Very good morning to all of you. So I'll be speaking on a new trifocal IOL, no financial interest. So what are the challenges in multifocal IOLs that we have today? One is patient selection, IOL selection, patient counseling is very important, and you need to be extremely precise in your biometry as well as in surgery. So what we do in our setup is basically repeat readings are taken for all these patients, ensure that the readings are taken on virgin corneas before any anesthetic drop or applanation tonometry is done. Proper ocular surface assessment, topography, OCT macula in all these patients. Also look at the pupil and angle alpha. Now, as regards astigmatism, we just put in the K1, K2 on the Barrett toric calculator and then decide whether the patient needs a toric multifocal or not. Yes, you can also discuss the other options with the patient. But all of us know that like an ideal husband, an ideal multifocal IOL is also a very elusive thing. So all you need to do is, in order to choose what lens is best for your patient, you need to be a matchmaker. So you need to communicate to the patient, explain to him what you are going to give, understand what are his visual demands, expectations, and then what we do is basically ask 3 questions. One is the computer work. Here we are representing intermediate division with the computer work. How much of reading he does per day and what is the amount of night driving does he do. Now if somebody is doing daily night driving, then definitely we would avoid trifocals and even some ADOFs who would probably end up having glare and halos. So their advanced monofocals or monofocals would be the better idea. Some patients who feel that glare is acceptable to them, then you can go ahead and ask the next question as to how much of intermediate vision does he require. So suppose he is a computer executive who requires 8 to 9 hours of computer work, definitely you have to address intermediate vision. So either you give him a trifocal or you give him an ADOF, and if he also wants near vision, you can explain micromonovision to him. Also, you need to understand that many of these ADOF lenses who give only intermediate vision, you have to explain to the patient that he requires a reader. And whatever is the reading distance of the patient, what we do is, we give him an inverted paper to read and then see at what distance does he require the reading material. So do not over-promise all of these patients and also take an extra consent from these patients. So today what we have been using is the Ray 1 trifocal platform. So it's a 6 mm optic and aberration neutral aspheric lens, which is totally preloaded, has a 12.5 millimeter overall diameter, 0 glistening, and because of the aberration neutral aspheric optic, it gives a very good clarity and contrast sensitivity also. Also the number of rings are just 16, the central 4.5 millimeter is the diffractive zone, and beyond that you have the distance zone. if you look at various diffractive trifocals, so we know that whether it's any kind of diffractive IOL, there will be some amount of loss because of constructive interference. So here we have the minimum loss at around just 11%. The distribution is 52% for distance, 22% for intermediate, and 25% for near. Important thing is it's glistening free. So because of this, if you compare it with many of the lenses, affecting the quality of vision is minimum. So here we have a case where we are going ahead with a femtolaser assisted cataract surgery with a premium lens. So most of these patients, especially here we are doing a Ray-1 trifocal toric lens. So with a premium lens, a premium technology also is offered to the patient, and you have to go through each of these steps absolutely meticulously. So even though it's a flax procedure, there is a pneumo delineation. So you just ensure that the nucleus rotates well, superficial cortex is removed, and meticulous phacoemulsification is done. In these flax patients, irrigation and aspiration of the cortex, you have to be careful because they are vertically cut fibers. So this is the Ray-1 preloaded lens. You inject viscoelastic, and then from both the sides, you clip in the top cap, and you can see how the Rayner procedure is done. Here you can see the rings, and remember, for all these cases, you have to wash off the viscoelastic from underneath the lens also. Moreover, because it's a toric, and also the reason is because this has an Ammon apple 360-degree square edge. So even if it was not a toric, because of this square edge, it gives a very good rotational stability, but you have to wash out the viscoelastic from behind the lens. Now, one of the important features are it has an excessive wider contact angle compared to the other lenses, and it has a very good anti-vaulting haptic procedure also, because of which there is a good rotational stability and very less YAG capsulotomy rates, just 1.7% at 24 months. If you compare it with the other trifocals, it's absolutely comparable. You can see the light distribution as well as the near ad is around plus 3.5 for near and 1.75 for intermediate. This was compared to the Zeiss AT Lisa. You can see the defocus curve is absolutely comparable. There are a lot of clinical papers comparing it with the panoptics as well as the fine vision lenses. So this was another comparison with the fine vision as well as the Acris of panoptics and with the AT Lisa. So all in all these trifocal patients, you have to ensure that the patient has realistic expectations, take special consent, explain to them also about neuroadaptation. If the patient is dissatisfied, it's very important to understand what is the reason. Some of these times you may have a residual refractive error, poor ocular surface. Look at CME post-op at around 3 weeks. And also remember that these patients have to be very given good chair time pre-operatively. So a premium trifocal IOL is easy, safe, efficient, reliable, consistent, and reproducible, and Rayner has given us excellent results.
Thank you, madam, for a concise and specific presentation.
Thank you.
I noted that more than 1.5 minutes of your presentation was involved with that counseling of the patient, and that is, of course, important. That's under promise and over deliver. So I like that concept of near reading, like 40, 50 centimeter, tell the patient to hold and read it. So it's right. If we do it properly, then it turns into a jolly affair with the patient. Otherwise, if we don't do the counseling proper, I think it turns into a responsible marriage then. No questions? Sir, any questions?
Dr. Naga, especially you said we should wash off the viscoelastic behind the IOL. Would you not advocate hydroimplantation in these lenses?
So if it works
I have
well
been
in your
using
hands,
these lenses
yes,
a lot,
yes.
and they are when a patient is very happy,
Yes,
but
you
I
can
do with
definitely do.
hydroimplantation.
But for those who are using viscoelastic, you need to wash it. But in spite of that, the capsulotomy rates are really very less. That's because of that 360-degree Ammon apple square edge also.
So we call upon
Thank
the
you.
next.
Thank you so
Thank you, madam. The next speaker is Dr. Pawan Puneet Malhotra. So sir will be speaking on advances in SF IOL and secondary IOL.
A very good morning to all of you. First of all, the timer, I think the 6-minute timer has been set. The talks are of 7 minutes, so that's making a difference actually. So with due regards to my teachers in ophthalmology, and thanks to us for the talk, I will be explaining this secondary oils and the SFOLs with the aspects of proline user and the post-POBH use. We all know that the secondary oils have progressed from the suture to the sutureless to the various Yamanis and Carlivali and nowadays indigenous SFL technique. Over time, the railroad technique and tram track technique, we know that passing the suture on the two sides, on the reversing it back and making it a parallel suture, and then cutting the two ends of suture and pulling the 4 knots. Handling these knots, and without a scaffold, then the knot externalization has always been an issue. You got jumbled up with the things, with the sutures end. Or in the case of corneal opacities like this, unfortunately, my friend had planned a triple procedure but had a drop. So I did the phaco-fragmentation and followed by the suturing the port, and thereafter, what's the difference in this technique of the suture loop is you directly pass the needle to the main port, just get it from there, and pass it through an eyelet and make a loop around that. So no need of just putting the sutures and handling that. And similar thing is done on the other side, but with the caution that the measurement should be accurate to avoid the tilt. And the case is like the de-enclaved ACL is there, and you have a support on one side. What we can do, just put the suture on one side and use the other side support, and the job can be done. This is our SFL technique, which has been acknowledged by American Academy of Ophthalmology. I will be showing.
With advantage of not requiring any forceps, any glue, no haptic exposure, no hydrophilic oil, obviously no suture, and can be performed through 3.2 millimeter clear corneal incision 2. Center of the cornea and adjacent limbus marked accordingly. Localized peritomy performed. Infusion source applied. One can use the AC maintainer too. Scleral pockets fashioned parallel to limbus with right-handed directed inferiorly and left-handed superiorly to match haptics direction. 1.5 millimeter marks applied at the entry of pockets. 26G needle with silicone band segment prepared. 3.2 millimeter corneal entry made. Holder folder forceps. Injector or simple curved forceps to fold and deliver the IOL. Needle brought out taking care not to pierce any corneal tissue. Haptic threaded over 26G needle followed by IOL delivery. Haptic brought out and retained with the aid of silicone band segment, obviating the need of any assistant. Similar procedure performed on the other side. For haptic insertion, just hold anterior sleeve of the pocket and slide therein only to save off any haptic exposure. Port is hydrated and cautery applied to oppose conjunctiva. Compared to Yamanis, this technique has no trailing haptic issues. A hydrophobic lens is used. No glue or trained assistant for IOL injection is required. No haptic exposure or special forceps as Gabor-Sherrod forceps for haptic insertion is required.
Thankfully, the technique turned out to be the most commented technique for the persistent 7 months on the AO site. And coming to the other usage, we know that proline suture has been used for the adolescent repair as well as the photoplastoplasty, but as it was with Dr. Agarwal technique. So what are the other uses? That IOL tilts, subluxations, and the silicone IOL retention suture. So the idea came from the iron guards as we use at homes, and you can place these sutures in the center or the paracentral according to tilt, and you can see that even the tilts up to 90 degree, the lens is just staring at the cornea can be corrected. This is a small video. Mark the axis of the lens perpendicular to the axis of the previous tight side. Do the localized peritomy, then the mark and the cautery can be done. 1.5 millimeter marks are applied. Thereafter, 3 to 4 millimeter behind that to make a scleral pocket slightly larger inside. Believe me, that get fused without any suture or anything required. And you do paracenters and check for the orientation of the IOL, whether it is inverted or it is not inverted, so that you can decide whether you want to pass the suture in front or behind that. Like in this case, we passed it behind. Straight end of the proline suture, bring it out, just pass it, reverse it back, and bring it out. Thereafter, you titrate the lens, bringing it parallel to the plane of the iris. And job is done. And we have even up to 13 cylinder of the cases have been corrected. Like in another case, you can see it corrected by the 0.75 cylinder.
On either side with the crease.
And this is used in cases of the toric IOL fixation and the multifocal IOL fixations. In the lasso technique explained, they used to just suture the bag only, but they stand a chance of cheese wiring. So rather than the bag, we pass the suture directly from the IOL haptic junction through the substance of the IOL. And a similar thing is done on the side, and the lens followed by the centration. And you can see the subluxity lens is multifocal. And in the toric IOL lens, you can see in this case, has been refixated back to the 62 degree, like this. This is a scaffold suture, which I will talking. That very interesting two cases. The retina was encasted in the tear. I did the retina surgery. Thereafter, the SOR, the visual acuity improved to 6/9. And another very rare case, subretinal nucleus, in the case of giant retinal tear. These are the sutures which save the cornea from getting the opacified and the visual acuity gain to 6/24. POBH, most of my colleagues do themselves. And at time they refer to us for in the case of PHPV. So this can be used to provide sturdier support like this case and to prevent the PCO. Nowadays we are using this for the anterior axis extension, traumatic case, uveitis and scandioil. As it's this case, you can see that anterior axis extension and the uveitis case, that lens can be provided very nice sturdier support and stability with this. And in the VKH and the JIA cases, keeping the lens away from the pro-inflammatory tissue substances like the iris can save you the phimosis and the CME later on. And dialysis with the PC rent or the opaque IOL, again, you explant the lens, fashion this opening to get a sturdy support. Otherwise, you cannot have to go for the SFIL only. And explanting the lens and then using the remnant part as a support can be an option using the posterior optic button holding, or we call the optic capture. In the traumatic cases, whether it's open globe injury, whether it's closed globe injury, or whether it's a case of a membranectomy, as I can do the rexis with the help of a rexis forceps, or the POBH can be easily done with the help of the cutter. Also, along with that, the anterior vitrectomy can be done, and the lens can be nicely placed, centered in such cases, providing again a centration and a sturdier support. And all these benefits I have explained. Thank you so much for your patient hearing, and thanks to my teachers for the talk.
Thank you so much, Dr. Puneet. Dr. Pan, how long have you had the follow-up for these, that they are stable?
So we have been doing this technique for almost 4 years now, and we have done more than 200 cases. Our rate of dislocation and the subluxation which is suspected is almost similar to the other cases, close to 2 to 3% only. Because if the lens doesn't go in 3 weeks, it won't go anywhere. The first 3 weeks you have to take precaution. Apart from the cornea healing, which gets a healing by the swelling of the fibers, the scleral fiber actually retracts when you cut the scleral fiber. And it's the intervening the blood and the cellular migration which heals the scleral flaps which have you ever made. And it is by the secondary intention, basically, like the derm is healing in our skin. So the lens, if you're taken care for 3 weeks, you can say the patient to avoid rubbing. It doesn't go anywhere, and like that.
Role of anterior chamber maintainer, like those who are initial, those who are not used to SFIOLs.
Yeah.
Have you ever used it?
Ma'am, we have been training, because many of the surgeons who come to us for the training of this technique, we have been using AC maintainer only. The concern was that in institutes like I am from PGI and from the AIMS, many of the students do not know SICS doing. So for the candidates who do not know SICS, for them making corneal tunnels and corneal injury, and in the scenario of countries like us, we are saving 10,000 rupees per case without using those handshake with the 2 forceps or the glue. It makes a big difference. Anterior chamber we are using routinely for all those cases. Thank you, sir. Yes, sir. Thank you so much, sir. Yeah. Yes, sir. So at the IOL haptic junction.
So passing through the substance of the IOL, will it be that easy? I mean, maybe it will be easy for you, but will it be reproducible in the hands of everyone?
Yes, sir. Actually, you need to give a counter traction with the help of a dialer with a second hand. Because you can easily pass through it, but then passing the needle, you have to give the counter traction with the help of a dialer. So it becomes messy at times because you have a very little space handling given it left hand. Actually, we got a myope being fixated for the SFR and of hardly, the lens was 8 to 10 diopter 3-piece lens, and the haptic got broken. So at that time we saw that it can be easily passed through that substance of the lens, and I thought I have done it, but later on I found that it has been explained as the cupid fixation of the IOL way back, many years back, when they used to pass through the center of the lens.
Yeah, it was described earlier also, but,
Yeah.
but then it was left because probably because of the cumbersome thing that
Yeah.
passing through the IOL material is a little cumbersome.
So especially, and this is boon for the multifocal eyes and the torical subluxation, where you don't have any other option for setting the toric IOL lens to the same axis, but it is fixated on the both the sides. Thank you.
That was very interesting with the tilted IOL, which you placed the two sutures behind.
So, and then another case, there was a decentration also, and we put another junction hook loop suture also. So pull the suture inferior also. So that place the lens centrally and it is the thing. Thank you.
Thank you. We would like to call our next speaker, Dr. Rajesh Sinha. We would like to be excused for jumping the queue as Dr. Rajesh has to go to another hall. He will be speaking on iris and pupil reconstruction with cataract surgery, different strokes. Dr. Rajesh Sinha. He's a
Thank you.
professor at AIMS and he was our earlier treasurer at AIOS.
Thank you, Dr. Satyajit. I'll be showing you a few scenarios. You all must have encountered situations wherein there's a cataract and you require some pupilloplasty or you require some iris repair. So there can be various scenarios and it will take a lot of time. So I'll just show a few scenarios with some logic why it was done like that. So it's a case of a partially absorbed cataract. You can see here it's a membranous cataract with an iridodialysis here and the iris synechiae and everything. So what are the issues? One is that whether we should repair the iridodialysis first or we should put an IOL, multi-piece IOL in the sulcus. So I feel we should repair the iris first, because if we make a membrane opening in the membrane and then do iris repair, then in that case there can be pigment release, we can go into the posterior segment, there can be inflammatory mediators release which can go into posterior segment and that can cause CME. So that was one. The second issue was that when you release the synechiae from here, I'll just move a little fast. When you release the synechiae from here, what happens that the iris tissue is all, they are crumpled a bit. So in such case, when you pass the needle from the tip of the iris here, you will see that the whole of iris is pulled onto one side and it causes some degree of notching. It has not caused in this bite, but in the other bite it will cause that you can see here that the whole thing is going away. And it is from the tip only. So what you need to do is that once you pass the needle, you have to stretch the iris. The folds that are created, that folds have to be opened up. That is important. And that is what is the thing. The basic idea is that you should just oppose the edge of the iris tissue at the root of iris and not tighten it very tight, otherwise it will cause notching of pupil and you will not have a pupil which is circular. Here I am trying to stretch it and very gently, so that as you can see here, the marks that you can see, these are all opened up folds, because that is why it is looking like white, depigmented kind of. And then you put more sutures, you have to put multiple sutures, and then once you have done with it, then you do a membranectomy and put an IOL in the sulcus, a multi-piece IOL in the sulcus. And the basic idea is that the edge of the IOL should not be in the pupil at all, even if you have little bit of notching. Although you should aim for no notching at all. This is the end of the procedure, and this is how it looked like. There was no notching, but because of the atrophy of the iris and because the folds were opened up, but still there was atrophy. So there was little bit of pulling here. The ideal one would be like this, but because of the atrophy of iris, it was slightly pulled, but still the edge of the IOL is behind the iris. That is what one should aim for. If you have a traumatic cataract with iridodialysis with a swollen lens, in such a case you need to create a space. Now if you want to create a space, you have to do a cataract surgery first. So release the synechiae here and then put iris hooks. You can put iris hooks here because the iris is not fluttering. I have not put the iris hooks, but in a large majority you may have to put the iris hooks here, because sometimes the iris will flutter, and then it will come into your probe, and then it will cause damage. Now, if you have a iridodialysis like this, and you have done a nice phacoemulsification, you can expect some amount of zonular dialysis also in this region. So endocapsular ring should be put in all these cases in the bag, and then you put the IOL in the bag, and after that you do the repair, because now you have created a nice space. And then even if there's a pigment release, it will remain in the anterior chamber only. You can, while removing the viscoelastic, you can remove it, because there's no opening in the posterior capsule. And this is what you should aim for, a circular pupil at the end of the procedure. Another scenario, or the last scenario actually, iris coloboma with cataract. Now, in such a case, if you do a cataract surgery, put an IOL, what will happen that this part will remain aphakic and this will be pseudophakic. So your idea is to do the cataract surgery first, and then repair the iris in such a way so that you can get a nice circular pupil. So the cataract surgery is done the same way as in anyone. Sometimes you get a very calcific cataract in these colobomas. These are hard and calcific cataracts. But this was relatively easier one. And then in all these colobomas, you have a tendency, because of the loss, there can be some loss of zonules also. So in all these cases, we should put an endocapsular ring, inject viscoelastic in the bag, put an endocapsular ring, and once the ring is there, now you have to do the repair. Now when you are doing the repair, after putting the IOL, you should remove the viscoelastic from the front and from the behind the IOL, because once you have done the repair, you will not go behind the IOL. And then after that, you inject high viscosity viscoelastic, and then the first suture should pass through the intended edge of the pupil. That is important. So this is the first suture. What I want is that the edge of the pupil should be like this. So this is the first knot that I'll tie, and once you have done that, then you can go ahead and pass. 2 more knots will be required in such cases. So 3 such knots, single pass for thoropupilloplasty, and then once you are done with it, then you can remove the viscoelastic, and you will have a reasonably circular pupil, and the pupil which is an adequate size also, so that you can view the posterior segment as well. So thank you very much for your patient listening.
Meticulous surgery, sir. I could see that 10 more people, I think at least 10 more people joined in the hall when your videos were playing. Questions, if any, Satyajit sir has.
Amazing video. Very good.
Thank you.
Thank you very much.
Thank you. Yeah. Yeah. Yes, we can. Only problem is this, that in a circular pupil, because it was still margin was circular, but because of the atrophy, it was pulling the iris tissue, but it was still, the IOL edge was inside. So the center of the IOL was behind and along the visual axis. So that was serving the purpose. Now, if you pass a knot like this, then you will create a fold in the iris tissue. That is one issue. That is one problem. So I didn't want to create a fold, because that fold, either it will go behind or it will come up. Other way of doing it is that you can just cut it, just put a nick and then put a suture. That can be done. But then when you have such a large dialysis with an iris atrophy, and you see that your lens is well behind and the edge is not coming, it's better to, be less manipulative and do less manipulation in such cases.
So I just want to understand one thing.
Yeah.
You said that we should be doing in cases the iodolisis repair first. But what I mostly prefer and doing, because of the inadvertently hitting the anterior capsule while doing the repair.
No, 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 no.
In the initial
The
and
iris repair is not done. In the second case, I did the cataract first.
yeah, I saw that
And
in the
then
first
did the iris repair. In the first case, I did the iris repair first because there was a membrane only.
membranous lens
So
was
if you cut the membrane and put the IOL and then do iris repair, then pigment release and inflammatory mediator release will be there, and that will go into the posterior segment, and that can cause high chance of CME.
As a beginner, I initially started doing the iris repair, iodellus repair first, so that I do not puncture the anterior capsule while the repair. Secondly, the one more point that before doing the pupilloplasty, what I prefer is putting some pilocarpine, so that we know that how much of the rest of the pupil
Yeah,
is
yeah,
there.
I agree. That I completely
Pilocarpine
agree.
has
I
to
mean,
be put
obviously,
first.
all these things you did and then show. Obviously, you would not like to have a very dilated pupil and then do pupilloplasty. You would like to put the pilocarpine and then see what is the shape, and then you will put this.
Especially in the coloboma
Yeah,
cases.
yeah, especially in the coloboma one.
Thank you, sir.
Yeah. You could see when I started doing the repair, then the pupil which was, large, it had come down to a little smaller one. It was not that big.
Yeah, thank you, sir. So we invite the next speaker, that is Dr. Rishi Raj Singh, if he's in the house. Okay, then we move on to Prakhyat Roop, sir. Dr. Prakhyat Roop, then Dr. Kapil Agrawal. Subudhi sir is here. So Subudhi sir will be having his talk on prediction and prevention of post-operative dysplasia by modern technology. Yeah, so pleasure and dysplasia both are associated with modern technology. I do agree to that. So sir will be showing us the other side of technology.
Here.
Thank you, ma'am. So give me the opportunity to speak before you. I thank once again the AIOs giving the opportunity to speak in this forum. And unhappy patient is very common in everybody's practice. If you do 100 cases of good patient, but if you one unhappy patient, he will spoil your whole practice. So the best example being recently what you have seen in the media.
Sit by myself, talking to the
But once the surgery was over, arey, ye kya hua? And he started all this hype in the media. Everybody in the last 3 months back have gone through a lot of, outrage against the doctors. But if you see, the doctors are never at fault at that time. So unhappy patient is very common without doubt. One miserable moment in the life of an ophthalmic surgeon is unhappy patient. No matter how experienced or careful the surgeon is, despite the best efforts, there will always a small but vocal group of patients who are simply not happy with the results, more so when it is a VIP, like SRK. So whatever best you can, if you are very much skillful surgeon also, but you are likely to get an unhappy patient, you must be prepared for that. So as you know, cataract and glaucoma patients, unhappy is very common because whatever best you do, but still then the results are not very good. But it is most common today in patients with getting operated for cataract because you got a lot of gadgets available for you to give a max vision. And still then, in spite of that, also if a small mistake happened anywhere, not the surgeon's mistake, but it's really become a lot of sound in the media. So many times there is a balance between the surgeon's expertise and the patient's expectation, but nowadays the patient's expectation is very high because they pay more, lakhs of rupees they spend, so they expect more. So gone were those days, a Sushrut era, when just simply pushing the needle, with the cataract lens, and the patient were very happy. And now, present day of Kalman era, in spite of all our efforts, still we are not able to give a happy patient to all of our practice. So this is the results of present day as a phaco, femto, multifocal and more. So expectations has gone high. So even a 70-year-old man or 80-year-old man expects just a vision like a child he wants to do after cataract surgery. With the wide array of choices in the surgeries and the IOLs that are becoming market of ophthalmologists, is offering to the patient, these days patients are very much choosy. The best part about the media really creates a problem for us because everything is available in the Google. So once the patient comes to, he does a lot of homework at home before undertaking the surgery. So sometimes the surgeons are very much annoyed. They put a board in their clinic that patients will be charged extra for annoying the doctors with self-diagnostic gotten from the internet. So really it's happening in everybody's practice. The source of dysplasia both pre-operative, post-operative, a number of tests, because nowadays as the accuracy is gone, so we need all these tests to give the accurate, so patient is really tired of coming to our clinic, undergoing all these tests for more than 1 or 2 hours. And again, a big consent form is available to sign, not only him, for his relatives also. That's also very much displeasure by the patient. And post-operative, of course, anesthetic complications, suture and wound-related problems, post-operative astigmatism, erroneous IOL hampering in the clarity of sight, unrealistic patient expectations, and to add to those, reckless remarks by our fellow ophthalmologist. If he has done something gone wrong, something bad, the patient goes to the next ophthalmologist, "Hare, what did he do? He has taken so much money, he has not done." This is very common by our old fellow ophthalmologists, so one should avoid this. Anesthetic complications, as you know, even we have gone from the era of no anesthesia in the Susruta era to the peribulbar, retrobulbar, and nowadays, of course, our rescue the topical only mindset. If you can do topical, and I can give a really best happy patient, because one prick in peribulbar remains in the mind of the patient. Always says that, "Sir, still the prick is pricking me." So topical anesthesia definitely gave a very good rescue, and surgical wound, a lot of calculations have been done to prevent this post-operative astigmatism. Every surgeon has devised own technique of reducing the astigmatism. So the incision has gone from smaller to the 0.7 millimeter to give the best results to the patient without any astigmatism. Suture-related problems, nobody wants to have sutures. Definitely sutures are nowadays null, and the suture companies have closed down. Foldable IOLs, yes, lot of foldable IOLs are available in the market. Today, one lens, tomorrow another lens, and whichever the company, motivates you, you go for his IOL, and you say that this is the best IOL. But if you surgeons, and this is one of the, you have to choose. There are a lot of competitive market, lot of lenses, lot of surgeons, companies lucrative incentive to the doctor. So all these things are presenting a choice of IOL. Again, IOL power calculus is very important. If you make a small mistake in IOL power calculus, you will land in SRK phenomena. So I will say that SRK phenomena, because why SRK was very unhappy because of this only. So a dream of a new vision. Every patient, when comes to your clinic, he expects a new vision. He doesn't want to use any glasses. So a perfect vision for both distant and near, and that stimulates us to produce a multifocal IOLs. But multifocal IOLs is a limitation. The surgeon has to choose which patient should go multifocal IOL with the trifocal, monofocal. You have to choose. That's the most important decision you have. So multifocal IOLs is where the technology modernized to rescue with us the modern gift of multifocal IOLs. But still, even if in spite of multifocal IOLs, also patients are very unhappy. So now they come with a toric IOLs, again, still pushing the limit of optics to help those with the preoperative astigmatism to achieve excellent positive result by the important interest of toric IOLs. So multifocal toric IOLs are now the need of the hour, but in spite of this lens also, there is a small group, it may be 0.0001% of patients, they make your life a hell of a trouble. So be careful, counsel the patient properly, probably you may not expect the good result. So modern technology, whatever they help us, but still there is a lot of things to gather knowledge, because there's a media is other hand against us. And the patients are now mostly demanding and are impatient and seek immediate gratification, have unrealistic expectation, and above all, have a lesser and lesser faith in their surgeons, because you have paid money, so they lose their faith in the surgeons. So to conclude, many a times post-operative vision fails to up to the mark, whatever you do, not due to the surgery, but due to the pre-existing issues like diabetes, hypertension, old age, so many things, macular degeneration. But the various tools of modern science, it's today in our capacity to detect them preoperatively, counsel them properly before undertaking the surgery. Most importantly, counsel the patient so as to avoid post-operative dysplasia by patient, mostly if it's a VIP patient. So thank you very much. I think I could give you comprehensive. Be careful before doing your next surgery. Thank you.
Thank you, sir. You have rightly shown the other side of cataract surgery. So as we are seeing in ophthalmology, inpatients are becoming less and impatient patients are becoming more. Doctors, they just need to be patient with the patients who are not patient. So any questions or comments on the whole session from the house, the audience, and convener, sir?
So I just wanted to share with my junior colleagues that sir has beautifully explained the whole thing. But once, in case you, God forbid, if you have a complication, the best time to talk to the patient and the attendant is right after the cataract surgery. Do not send, once you have a complication, do not send to the ward that I'll finish all the next 10, 15 cases and then go and talk to the patient attendants. Once you call them to the changing room, they are most forgiving at that time. Everybody knows and understands that any complication can happen when you're doing a surgery, but when you talk to them at that time, they are most forgiving. So it's a good idea to talk to them right away rather than to keep them waiting for the end of the day and then talk to them. But a very nice presentation.
As you said, that's right, but when a complication occurs, they immediately become panic, and if it's a VIP patient. So the panic creates all the problems for you.
Not only VIP, sir, anybody, and if you operate on anybody and any complication happens, even if it's a poor person, you should call their kith and kin and then talk to them at that point itself.
Sir, a question for you. Who operated on Shah Rukh Khan?
No, my question is what actually happened to Shah Rukh Khan? What was the problem?
There is, I think, miscalculation. The IOL, I believe, there's a miscalculation. I don't exactly, I can't say, but I heard that he has undergone LASIK surgery earlier. Probably there is something happened to the doctors. That's otherwise, the lens was in proper place and everything was quite good. Maybe some surprise in the
IOL calculation.
diopters, I would say.
But thank you very much.
Thank
We'd
you.
like to
Thank
thank
you.
the audience also for being here. We'll have a group picture just now. Thank you very much to everybody for this session.
So inviting all the speakers for a group photograph.